Hi, good afternoon, everybody. I have come from the OBGY Society. I'm an IVF specialist practicing for the last 25 years and with a great interest in oncofertility. And I was very happy to be here today to talk to you about fertility preservation in cancer patients. I think one thing that we must remember is that today cancer therapy has become very good. People are surviving it, and they are surviving it to tell a tale. They want to get married, they want to have children. So we have a responsibility towards them because we need to do the counseling. And the whole disruption in medicine is because of some discovery or the other. And cryopreservation was a major discovery in IVF or in fertility, and it has really changed the whole scenario of looking at patients. And oncofertility it's a big thing. We take it very lightly over here, but we need to understand the requirements of these patients. And it's by itself, it's a whole new aspect which needs basically fertility preservation, discussion, and management. It also includes the management of sexual dysfunction, the hormonal dysfunction that can happen because of therapy. There's complex contraception involved in this and fertility related psychosocial support. So, this entire package is what is oncofertility, and we really need to wake up to the fact that we need to offer this to our patients. In fact, if you see in adolescent cancer patient, one of the 5 unmet needs is fertility preservation, along with health, work, school, romantic relationships, close friends, etc., because these are young children who are devastated by what happens to them. And we need to support them. And we need to address this because this is genuinely one of the unmet needs. It's often under-implemented, the fertility preservation. Why? Because of lack of referral. You don't understand where to refer to, which center is good, etc. Then cost, inequitable access because it is expensive, the fertility preservation. Then health literacy. I think even doctors, there was a beautiful study which was conducted, and it showed that the IVF specialists, 50% of them did not offer it. I mean, they are unaware of it. They thought it was experimental, the oocyte freezing. So that health illiteracy is also a problem, a lack of trained staff who can deliver these services, and no consensus about the best way to deliver these services to the patients. So if you look at a fertility preservation strategy, it's an intense cooperation between the fertility experts, the oncologist, and the other healthcare workers plus the patient. So what affects it? You look at the patient age. Obviously, a younger patient, you offer her fertility preservation. Cancer type, some of them are very aggressive, life expectancy is low. Then type of treatment or presence of a male factor. Obviously, you can preserve embryos. I'm going to talk about that. And time available for fertility preservation interventions and likelihood of ovarian metastasis. I think these are important factors which we must remember. So when you're counseling a patient, you talk to them about fertility preservation. Also at the same time, there are certain cases where they don't require it. Their fertility is normal and they come back. So it's like an insurance policy for them. Of course, some may require oocyte donation and adoption. So these things should be discussed. So what are the factors that really push you and tell you that this is a good patient for fertility preservation? Good prognosis of cancer therapy. If your therapy or your surgery is going to have a high risk of premature ovarian insufficiency, that's the patient. And age greater than 35 years at the time of expected pregnancy. Sometimes you've treated a young child and the treatment takes a long time, 5 to 10 years before they can actually think of settling down and all. So you need to keep that in mind when you're treating them at that 15 years of age or 20 years of age, that Baba, she'll be 35 when she wants a child and she should be okay. So I think all these factors need to be remembered when you're counseling a patient. So what are the different things that are available? This chart is beautiful. Actually, in this chart, everything is explained. You know, the malignancy diagnosis is there, fertility preservation counseling by reproductive endocrinologists, that is us. You can refer to the IVF center and they would do it, and selection of the most appropriate strategies. So, strategies can be pre-treatment, can be co-treatment, and post-treatment. So what are the things? If you see, the dark blue ones are the established strategies where guidelines are already there and it's in clinical practice. So embryo cryopreservation, mature and immature oocyte preservation. Oocyte preservation is also now clinically established. Isolation and cryopreservation of follicles, isolation and cryopreservation of ovarian stem cells, and differentiation of other stem cells towards the oocyte. Ovarian tissue cryopreservation can be offered to prepubertal. Those were the postpubertal girls. Prepubertal girls, ovarian tissue cryopreservation, isolation and cryopreservation of follicles, isolation and preservation of ovarian stem cells. See, a lot of these things are not being done. What is being done is embryo freezing, oocyte freezing, and ovarian tissue freezing. So these three are clinically established treatments which are available in our country, in our city, and we are doing it for a lot of patients. So co-treatment strategies are oophoropexy and ovarian shielding, which you can do, and radical tracheotomy, progesterone therapy, conservative therapy, depending on the cancers. GnRH analogs are protective to the ovary, injection of SIP using AS101 as a cyclophosphamide inhibitor, and also oophoropexy and ovarian shielding when the girl is prepubertal. Then post-treatment plan, obviously embryo thawing and transfer whenever she wants a baby. If it's oocyte, then oocyte thawing, and with her partner's sperm we can create the embryos and do an embryo transfer in her. If it's ovarian tissue thawing and transplant, and in vitro, if they are, the ovarian stem cells, then I will talk about it later. I will go on. So now, this again, I think my talk actually is in these two slides, the previous slide and the two slides which follow, because the advantages and the disadvantages of all the technologies that we can offer the patient are actually put here. So let's take the first technology, which is embryo cryopreservation. So this is a young girl who's married, who has a partner. You can create the embryos. I had a patient recently with I think it was rectal carcinoma, and she came back, and we preserved her embryos, and she did surrogacy transfer, and they're soon expecting a baby. So this embryo preservation is well established, most reliable, very high pregnancy rate, best option available when there's enough time available before the treatment starts. The disadvantages is, prepubertal girls, you can't offer it, requires a male partner or a sperm donor, requires ovarian stimulation, takes 2 to 3 weeks, and arising some ethical concerns, non-applicable for women who have hormone-sensitive cancers. It is expensive, it's an outpatient surgical procedure, low pregnancy rate, but acceptable fertilization rate. And I think that low pregnancy rate needs to be removed from there, because today the IVF success rates are very good, and if you have good embryos, the pregnancy rates are definitely good. Come to mature oocyte cryopreservation, applicable for singles and those who are not ready for sperm donation. No ethical problems, no urgent need for sperm, no delay in cancer therapy, higher fertilization rate as compared with mature oocytes, no ovarian stimulation needed, no risk of OHSS in PCOS patient. This is of immature, sorry. So let's go to only the mature ones, and the mature oocyte cryopreservation is an established practice. We've frozen eggs from a lot of young girls, of course, for cancer therapy, breast cancers, as well as for lifestyle, and it's giving very good results, and it's perfectly fine. If you look at immature oocyte, the fertilization rate, the pregnancy rates are slightly lower with immature oocyte vitrification, and what we do is in vitro maturation, and we can get these eggs and freeze them. Ovarian tissue cryopreservation, the only available approach for pre-pubertal girls and women who cannot delay the start of chemotherapy. It allows natural pregnancy after autotransplantation, carries fewer ethical dilemmas, no ovarian stimulation is needed, and there's no need for a partner or a sperm donor. So, what is it? Low success rate? As of date, nearly, I think, 10,000 women's ovaries have been frozen in the world, and about 100 plus babies have been born. And I think it's a very good technology. It's pretty much stabilized, and there's a lot of debate going on whether which technology, slow freezing or vitrification, etc., etc. But otherwise, it's a very well established technique. It has some complications with activation of primordial follicle. Normally, after thawing and transforming, 10% follicular loss is seen in that cortical tissue, and some safety and ethical tissue issues forming xenotransplantation. You know, what we do is, supposing the ovary has a high chance of metastasis, like leukemia, then you can put it in a mice and grow the eggs, remove the eggs, and then use them for fertilization. So those ethical and safety issues are still there. Not recommended to be performed during controlled ovarian stimulation because the ovary is very friable and it's difficult. You can have problems, and potential of risk of cancer recurrence. There have been studies where I think one patient has been shown to have a recurrence, but the recurrence is not does not affect the life expectancy. So it has been shown through the research that this is possible. Then oophoropexy, can be performed for all ages. It's simple, safe, effective by a laparoscope. It can be performed immediately before pelvic irradiation. Ovarian function can be preserved, no ethical problems, no surgery is needed. It's not expensive and easy to perform. And the disadvantages is, a second procedure is needed to relocate the ovaries back to the pelvis for spontaneous pregnancy. We've done oocyte retrieval. I've had a lot of patients who've come down from America where the ovaries has been in the abdominal cavity. We did a laparoscopic pickup for these people and did surrogacy. Then I will end it over here. GNRH analogs, not expensive and easy to perform. Spontaneous pregnancy is possible. Ovarian function can be preserved, and it needs some evidence to be more applicable. Thank you. Thank you very much.